Yeah, at this conference, I was talking about various clinical trials. On one hand, it's a clinical trials on the so-called targeted therapies, so the MEK and BRAF inhibition, and the latest results. It was an update on these clinical trials, namely dabrafenib and trametinib, and on the other hand, vemurafinib and cobimetinib. And also I'm talking about the visions, on targeted therapies, how they will be used in the future. On the other hand, it's immunotherapy, which is an attractive topic at this conference, and it's the PD-1 antibodies, which are making the difference in our days in combinational treatment of nivolumab and ipilimumab, namely, which is becoming a standard of care if overall survival data are available, but they are not available at the moment. So this conference will not contribute to the knowledge of the overall survival of the combo. So VISMO Degib, as the trade name is Erivedge, is approved since 2012 in Europe, and it's a drug which is making a difference. The only active systemic treatment for advanced basal cell carcinomas, locally advanced as well as metastatic basal cell carcinomas. It presented already a response rate of almost 60%. The response duration was in an update around 2.5 years, and there's roughly 30% of patients who have a complete response. And therefore, it's a discussion of this is standard of care for these rare subtypes of basal cell carcinomas. There's various BRIM studies. So one is BRIM 3. And in 2 months from now, we will learn more about the 4-year survival of BRIM 3. It was a trial which was bringing vemurafinib to the market. So it was a comparison of vemurafinib and DTIC, so conventional chemotherapy. And we have presented a pooled analysis of various BRIM studies here. So we conducted a pooled analysis of predictive factors for response and for long-term survival of either BRIM 3, which is vemurafinib compared to DTIC, BRIM 7, which is cobimetinib and vemurafinib, and CoBRIM, which was a clinical trial bringing the combination to the market. This was comparing cobimetinib, vemurafinib, to vemurafinib alone. So it was setting a new standard of care, and the new standard of care is a combination of BRAF and MEK inhibition. And this study showed that there is very good long-term survival, particularly in those patients who have low LDH levels when we initiate the treatment. So the simple blood marker of LDH is making a difference in the prognosis of the patient, but also it's a predictive factor for response. The patients have better responses and long-term survival once they have low LDH. The checkpoint, it's called Checkmate trials and Keynote, and it's more or less the clinical trials on the PD-1 antibodies. And we have no new data here, but 2 months ago at the ASCO meeting in Chicago, there were releases of long-term survival, and there's surprisingly long survival after 4 years. And we have data already for nivolumab after 5 years in a range of 32–33% of patients surviving 5 years, which is an outstandingly good result. Don't forget, 6 years ago, we had a long-term survival of 5 years in 5% of the patients. So we have an enormous increase in overall long-term survival, and this is something really making a difference. So the PD-1 antibodies are making a difference, but as I pointed out, PD-1 plus ipilimumab could make another difference, but there is no long-term survival data available. We need to wait for overall survival. That's a very good question, and there was a presentation at ASCO in the Health and Economy session, and I can tell you in Germany we have a very good situation. Once a drug is approved on the European level, it's immediately paid by the health insurance companies for everyone. So it's very fortunate. And then within the next 12 months, the companies need to demonstrate the superiority of the new drug compared to the old standard of care. And once they demonstrate a high difference, big difference, the magnitude of benefit is exciting, they get a good price. If it is less good, they receive a lower price. And that is a very fortunate situation. But the dilemma in Europe is, in very many countries, the drugs are approved, but they cannot be used. They are simply not paid. And it is a long time in other countries before the drug is paid, if it is paid at all. And then we have countries, particularly in Eastern Europe, where none of the new agents is available. They are approved, but nobody can afford for it because the patients need to pay out of the pocket. And this is a dilemma. And here was a presentation, and this is at ESMO in 6 weeks from now is another presentation of our organization who is running this congress, the EADO. And this is a study conducted by Lydia Sekulovic from Belgrade. And she pointed out that 5,000 patients in Europe with metastatic melanoma are not receiving the new agents because they cannot pay for it. I think this is a dilemma and we need to work on it.